how a vaccine is put on trial and how do we know the adverse effects prior it is put out there for the people to use it?
Would you like me to do that? Ivor, is that okay?
Oh, go for it, yes.
Okay, so the idea is, what is a vaccine? A vaccine is basically a molecule. So it can either be made in the laboratory or it can be an inactivated or in some way a killed or a reduced function organism which is injected into the body to teach the immune system what that foreign body is. So the next time it's encountered, the immune reaction is much more rapid. So that's the short. We can go into more detail, but that is, I think, sufficient. How are they tested? The way they are tested, first they're tested on laboratory animals for efficacy and also for adverse effects. They're then tried in human volunteers, and we can talk about the ethics of that because it's not very nice what some of these people are put through. But there are people who are paid to get drugs, including vaccines, and to study what are the potential side effects. They're even given these medicines in higher doses, etc. Once the information from that stage is collected, they then start small-scale studies. But eventually, the whole basis of the information you get on the leaflet and the information in the medical literature is a randomized, controlled trial. So you basically have a group of people who are given the... Let's focus on the vaccine. A group of people are given the vaccine, and a group of people are given usually either a placebo injection, which is usually, for ethical reasons, another vaccine which is known to be effective, but for a completely different disease. You then follow these people over a period of time, and you see how many people in both groups get the disease. You basically get a relative efficacy. You then work out the absolute efficacy in the real world based on the risk. So there's a bit of mathematics there. But you're basically looking for a statistically significant and clinically significant, so big enough an effect, which is statistically significant. It's not come out due to chance. And that then becomes the standard. This is how effective this drug is. What about the safety? The problem is, as Ivor has correctly said, the adverse event rate should be much, much lower than the chance of the benefit, obviously. Otherwise, what are you doing? And we can talk about that with regard to the COVID vaccines. But then you have these rare or uncommon side effects. You have the commoner and mild, usually because you're provoking an immune reaction. You get fever, a bit of irritation at the injection site. But you can get heart disease, you can get renal disease, you can get liver disease, you can get strokes, you can have problems with circulation. And these can be quite rare, but important. So you have to know exactly what the risk is. And to do that, what you do is you look at the difference between the two groups. One is getting maybe another vaccine where you know the adverse event rate. And then you're looking at this. But you have to follow it up for a number of, usually, years. And this was, in a way, you can excuse the way that the COVID vaccines were rolled out without having these years, months or years of prospective adverse events rates. But what I find unforgivable is that these studies, which should have gone on, so these are the randomized controlled trials, which should have gone on to 2023, 2024, 2025. And they were curtailed, they were stopped early, with the argument that we have now enough exposure in the population, we have enough data. No, you don't, because you don't have the randomized, the randomization, the two groups, which one will never get the COVID vaccine, the other just got one shot, and you see over time what happens. However, the probable adverse event rate was probably something around one in every 4 or 5 or 6,000 people vaccinated the first 2 doses or the 1 dose of AstraZeneca and Johnson & Johnson. But these are the serious adverse events. And when you come to vaccinate children, where the risk from COVID was practically zero, and Ivor was one of the first people who came up with those data from Ireland, and I admire him for saying that, and I use that in my arguments against vaccinating, especially children, here in Malta. you need that information. That information is crucial for the risk-benefit analysis, and that was not done. And what usually in the pharmaceutical industry, you go to these authorizing bodies which look at these adverse effects, look at the benefits, and basically come up with recommendations, also lists of potential side effects, which all go onto the leaflet. And it usually, the approval time usually takes years, up to 10 years, and then it's approved by a committee with a list of all the adverse events. What we had instead is we had people saying that these vaccines are fully tested, which they weren't. They're safe and effective when you didn't have the bio-distribution data, the bioavailability, where it goes, what it does. And so that was a failure of the supervision process on the pharmaceutical industry. I don't know whether you agree, Ivor.
Yes, your view, Ivor, please.
Oh, absolutely. I'm delighted, Jean Paul, you went that kind of direction, because I threw some slides together just for this. So the critical thing is, exactly as I said, only a randomized control trial can truly tell you what their risks and benefits are, because it's real science, because it's controlled. It's fundamental. And we do have the Pfizer 6-month follow-up published. And interestingly, Professor Norman Fenton went through the data, did beautiful graphs. And unfortunately, in the vaccine arm, there were 6 more deaths than in the control or placebo arm. So it's 21 versus 15. Now, it wasn't statistically significant, luckily for Pfizer, but around that stage when they saw this, because there was a trend towards the vaccine being worse than nothing, as you said, they brought in the control people, placebo, and they gave them all the vaccine. And that's what we call in engineering killing the control. Yep. In other words, if you see the wrong trend, you kind of need to kill the control, to be honest. This is just a thing, it sounds like conspiracy, but this is an actual fact. So what do we have from the randomized control trial then in terms of side effects or harms? Because we know if anything, there may be more death with the vaccine versus placebo. I mean, that is the trial data. We can't deny it. And in terms of adverse events, serious adverse events, that was published in 22 in Vaccine Journal. And it was 18 per 10,000 vaccinated from the trial, serious events, versus 12. So rough and tough, somewhere around 1 in 1,000 from the trial, the real data, might expect a serious adverse event. Now, I'll finish now with something which I think, if in doubt, zoom out and look at the figures that Jean Paul mentioned, the actual impact of COVID versus 1 in 1,000, let's say, serious events with the vaccine. So Claire Craig with the Heart Group did a brilliant report a couple of years ago. And from the UK data, the best data, in summary, below aged frail, down in the 40s, 50s or 30s, all the way down to children, roughly speaking, the chances of severe hospitalization from COVID itself was 1 in tens of thousands to 1 in hundreds of thousands. So the problem you were addressing was a 1 in hundreds of thousands for the broad population. And you were bringing in a 1 in maybe 1,000 risk of serious impacts. So the mathematics said, before we had any follow-up studies, which have all come out to be pretty nasty, the mathematics said that this thing was absurd. And I think it's important people understand that. It's not that this thing was kind of equivocal, or maybe take it, maybe don't. It's actually mathematically farcical from the trial data and from the actual government data on mortality and hospitalization risk. And I think that's just it. We need to say, how did we end up creating a farce of like colossal proportions by doing a coerced, forced rollout across the whole population, including children, when the numbers said it was insane? I mean, that's the interesting question for me.
And I have another concern. This concern to me is huge. These random trials are done on healthy people. What happens when the vaccine is distributed to an uncontrolled environment where you have patients taking other medication and maybe vulnerable people?
Well, let's break it down. Ivor is precisely correct. I mean, I haven't seen the report where it's up to 1 in 1,000, and I'm not doubting that in any way. What I remember was the German Surveillance Institute, and I now have difficulty recalling the name, Erich, but there's another word.
The Koch Institute?
No, it was the Public Health Institute in Germany. They came out very early on saying the serious adverse events rate was between 1 in 4, 1 in 6,000. However, I'm not disputing, with the randomized control trial, you have a better chance of picking up differences. The problem is, as you explained, if the sample isn't large enough. So the sample is large enough to pick up the efficacy of the vaccine, but it's not large enough to detect the adverse events up to a level of statistical significance where you say they're not due to chance. So you're in a bit of a quandary. Ideally, you want a much larger study, but they're very expensive. And it's true that these are very difficult to run, very difficult to maintain, very difficult to fund, and they wanted to have this done quickly. But Ivor's perfectly correct. There was a trend to this increased mortality. There is obviously a harm from the vaccine. Nobody's disputing that. However, the problem is COVID-19 is one of those very few diseases, maybe even unique, where the mortality index is something around 10,000 over age groups. So in children, the chance of dying of a COVID-19 infection is like 1 in a million, maybe 3 in a million. And if you go up into the elderly, it might hit 10 to 15%. So if a 1 in 1,000, if the 1 in 1,000 serious adverse event rate is absolutely unacceptable in children, and I have always been against the vaccination of children with the COVID-19 vaccine, it doesn't make sense. The vaccination of those who've already had an infection and have the natural immunity. But then when it comes to the elderly, when you have a disease with a mortality of 10 to 15%, elderly people, I'm talking, my first recommendation was to have it if you're over 70. These days I would say over 65. If you're over 65, if you have additional vulnerabilities, comorbidities, and getting a COVID infection, if you've never had it before, can still be lethal. A 90-80% reduction in mortality, which you do get from the vaccine, is worth the 1 in whatever it is, 1,000, maybe one in 10,000 additional risk of mortality. I think it's much less. I think there was an observational study in the UK which looked at the excess mortality after COVID vaccination in the under 28s. I think it was 18 to 28 or 16 to 28 in a large cohort in north of England. And they found an excess mortality in the first 28 days after vaccination, the region of 1 in 300,000. So there is obviously an additional risk of dying after the vaccine. But you also get that from COVID. So it's all about the relative numbers. And Ivor is perfectly correct. This is a mathematical formula. In my opinion, and I think that of Vinay Prasad in the States, but Charya was, I think, also along the same lines, this should only have been recommended for the elderly, those who have not had a COVID-19 infection and are over 65 or are otherwise vulnerable. Then there are benefits over the risks. But otherwise, I think this was, I would use the same word. It was a farce.